Let's talk briefly about potassium regulation. Potassium is an important component of our diet, and in general, potassium dietary intake ranges from about 80 to 150 milliequivalents per day. In terms of processing of potassium in the GI tract, most of it is absorbed in terms of about 72 milliequivalents per day. A small amount is lost in the stool, which can be accentuated by diarrhea. This 72 milliequivalents of potassium that is absorbed per day is deposited in the extracellular space. This extracellular space is in constant flux with the intracellular space. And notice your intracellular potassium is where the bulk of total body potassium stores are. So remember that potassium concentration inside the cell is much higher than any other electrolyte. And the bulk of potassium in your body is intracellular. Notice that what is absorbed in the GI tract is essentially what is in the extracellular space, the same amount per day. That has to be processed quickly by the kidney so that we don't become hyperkalemic. And remember, our serum potassium is in a very, very tight range of 3.5 to 4.5 milliequivalents per liter. The kidney handles this 72 milliequivalents of potassium that's absorbed from the GI tract per day and essentially gets rid of almost all of the potassium that you take in. So if you take in 80 milliequivalents of potassium in your diet, 8 of it is eliminated by the feces and the rest is eliminated by the kidney. Let's look briefly at the regulation of the intracellular to extracellular equilibrium. And recall that the bulk of the potassium is intracellular. And a small amount is extracellular. Factors that are related to the increase or decrease of this particular ratio have to do with hyperkalemia. If your extracellular potassium is high, it tends to favor deposition intracellular. Alkalemia does the same thing. And alkalemia, remember, is an increase in bicarb. So one of the strategies of pushing potassium from the extracellular to intracellular is adding bicarb. Another strategy is prescribing insulin. So insulin will push extracellular potassium intracellular. And then finally, beta-2 agonists can push extracellular potassium intracellular. Well, what does the opposite? Hypokalemia tends to bring potassium out of the cells into the extracellular space. Acidemia does the same thing. So if the particular patient has a decrease in pH or a decrease in bicarb, we may see a relative increase in extracellular potassium, and that may be reflected in the serum potassium. Hypertonicity can do the same in terms of pulling potassium from the intracellular space to the extracellular space, and exercise can do the same. So patients who exercise during exercise may have a mild increase in their serum potassium. In terms of treating hyperkalemia, strategies include things that we've talked about: increasing the pH via giving bicarb, giving insulin, giving a beta-2 agonist. Those things will shift potassium from the extracellular space to the intracellular space, but they'll only buy you about 30 minutes. An adjunct therapy is to give calcium to protect the myocardium, the action potential of the myocardium, from the effects of hyperkalemia. And you'll remember from our hyperkalemia talk that definitive removal does not involve bicarb, does not involve insulin, does not involve beta agonists, but involves diuretics, diuretics increase urine potassium loss. Other definitive removal includes K-exalate, and K-exalate works by exchanging sodium for potassium in the stool, so it works in the colon. And then finally, dialysis. And dialysis works by diffusion. High potassium flows down a concentration gradient to a low potassium dialysate bath, and potassium is definitively removed. So cell shift from extracellular to intracellular using bicarb, insulin, beta agonists will give you about 30 minutes of a relative decrease in potassium. But depending on the source of potassium, whether it's ongoing or whether it's temporary, you may need these definitive removal techniques.